Someone else's blood is about to enter your body, and somehow, your immune system is supposed to accept it. No alarm, no rejection, no attack. A nurse connects the bag. The blood moves through the tubing. From the patient's point of view, that can look like almost the entire procedure, but it isn't. Here's what hospitals don't tell you. The most important part of a blood transfusion may have happened before that bag ever reached the room. And once those donor cells enter your circulation, an entirely different process begins. Not just more blood. First, a blood transfusion doesn't always mean whole blood. Blood is separated into components. Red cells carry hemoglobin and move oxygen. Platelets help clotting. Plasma carries proteins and clotting factors. What you receive depends on what your body is missing. We're following the version most people mean when they say they got blood, a red cell transfusion. When someone is severely anemic or has lost a lot of blood, the problem isn't simply that they need more liquid. They may not have enough working red cells to carry oxygen. Do you actually need it? And this is the first hidden part. A low hemoglobin does not automatically mean give blood. Doctors weigh why it's low, how low, whether you're bleeding, your symptoms, your heart and lungs. For many stable adults who aren't actively bleeding, modern practice deliberately avoids giving more blood than necessary, often a single unit, then reassess. Because blood can save a life, but it is still a treatment, and like every treatment, it needs a reason. Your blood has an identity. If blood is needed, the laboratory has another problem. Your red cells have an identity. A, B, AB, O, and positive or negative. Those letters describe antigens on the cell surface. Your plasma may carry antibodies that recognize the ones you don't have. Giving the wrong ABO blood isn't a different variety. It can turn the immune system against the donor cells, and that can be life-threatening. The part most people don't know. AB and RHD are not the only markers. There are hundreds, more than 300 recognized blood group antigens. You are not matched for every single one. After pregnancy or a prior transfusion, someone can form antibodies against other red cell antigens. So the lab isn't only asking what letter you are, it's asking, is there anything in this patient's plasma that could attack the cells we're about to give them? That's the antibody screen. When it lights up, finding suitable blood can take far longer than patients expect. The cross-match. Compatibility testing can go further. Patient plasma against donor red cells, the cross-match. The question is brutal and simple. Can these two coexist? If antibodies create a problem, the lab identifies them and hunts antigen-negative units. That's why just get a bag from the fridge is a myth patients hear in dramas, not what blood banks actually do. The most ordinary-looking safety step. Then comes the part that looks almost silly. They ask your name, your date of birth. They check your wristband. They check the bag. You might think, didn't you already know who I was? They did. That's exactly why they're checking again. Blood can be perfectly compatible with the name on the label, and catastrophic if that bag reaches the wrong patient. Patient identification is one of the central safety barriers in transfusion. In UK hemovigilance, wrong blood in tube remains a major near-miss category, often from failed ID at sampling or labeling away from the patient. Those repeated questions aren't bureaucracy. They're the defense. If you're learning what really happens behind hospital walls, hit subscribe. We're exposing the codes and secrets that healthcare workers live by. Now the blood enters you. Only now does the part everyone imagines begin. Donor red cells enter a vein, mix with your blood, reach the right heart, get pushed to the lungs. Hemoglobin binds oxygen. Cells return left-sided and head to brain, muscle, organs. They may have belonged to another human being weeks earlier. Functionally, they're in your circulation now. The goal isn't to replace your blood, it's to raise the oxygen-carrying capacity your body can use. Why doesn't your body attack them? But this is the obvious question. These cells aren't genetically yours. So why doesn't your immune system destroy them on contact? Because transfusion medicine doesn't need every marker identical. It focuses on markers that cause clinically important reactions. The laboratory already tried to remove the major compatibility problems. If donor cells don't carry an antigen your antibodies are hunting, there's no reason for those antibodies to attack. They're not hypnotizing your immune system. They're trying to make sure dangerous incompatibility isn't introduced in the first place. If the match is wrong. Now imagine that protection fails. In a severe incompatible red cell transfusion, antibodies can lock onto donor cells and trigger hemolysis. Cells break apart, contents spill into the circulation, and the reaction can escalate fast. Fever, chills, pain, breathing trouble, dark urine, blood pressure changes, organ stress. Suspected reactions are treated as emergencies. Stop the blood, keep access, escalate, preserve the bag for the lab. What you don't see is the controlled chaos when that happens. The room shifts from routine to crisis, without always needing an overhead code. Acute hemolytic events are rare because of the chain you just watched, not because blood is casual. Wrong blood isn't the only reaction, and compatibility isn't the only watch item. Allergic and febrile reactions, breathing complications, and TACO, transfusion-associated circulatory overload, where the problem can be volume, not blood group. Too much fluid for that patient's heart to handle comfortably. That's why rate, unit choice, and just one more bag are clinical decisions, not hospitality. Why they keep checking when you feel fine. That also explains the observations before, during, and after. Even when you feel completely normal, they're hunting change. Sometimes the earliest signal isn't dramatic. It's, I suddenly feel cold, my chest feels strange, I'm itching, I don't feel right. During a transfusion, that sentence matters. You are part of the monitoring system. Say it immediately. You are not overreacting. Here's the reality most people don't expect. The bag can be empty, and the transfusion still isn't fully irrelevant. Some complications appear hours later, days later, occasionally weeks later. Fever, chills, breathing difficulty, unusually dark urine, jaundice, significant unexplained illness after recent blood. Those are reasons to seek medical advice and to say the critical line, I recently had a transfusion. Verdict: the invisible procedure. So when you see a dark bag hanging beside a clear one, you're looking at the visible fraction of the transfusion. Behind it, a clinical decision, a sample, identification, grouping, antibody screen, compatibility testing, component selection, another ID check, monitoring, and finally millions of donor cells doing the job failing red cells couldn't. Modern transfusion is remarkably safe because the boring steps matter, the label matters, the wristband matters, the laboratory result matters. And if you're awake when that blood is running, if you suddenly feel different, tell someone. Don't wait to see if it passes. Next time you're in a hospital and you see that bag, you'll know you're not watching just an IV. You're watching matched donor cells enter a living immune system under a protocol built from a century of hard lessons. Hospitals are controlled chaos, held together by codes, protocols, and healthcare workers who hang that bag knowing most shifts will be uneventful and staying ready for the one that isn't. If this helped you understand what really happens when someone else's blood enters your body, hit subscribe. We're exposing the systems and secrets that healthcare workers live by.